Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I'll be discussing a very important topic in the endocrinology, that is the Cushing syndrome. So I'll just give you a quick recap of this topic. First of all, you need to know that the adrenal gland, it has the two important areas, that is the adrenal cortex and as well as the adrenal medulla. So these are the two areas of the adrenal gland. Now, within the adrenal cortex, we have totally three layers. What are the three layers? So if you take from outer side to inner side, the outermost layer will be zona glomerulosa, middle layer will be the zona fasciculata, and the innermost layer will be the zona reticularis. So glomerulosa, fasciculata, and then the reticularis. So these are the three layers of the adrenal cortex, and out of which the zona glomerulosa is the site where there is synthesis of the aldosterone. Zona fasciculata is the site where there is synthesis of the cortisol or steroids. And zona reticularis is the site where there is synthesis of the weak sex hormones. So these are the three layers and their respective hormones from the adrenal cortex. Then you need to know what are the disorders of the hyperfunctioning adrenal gland. So for suppose if there is hyperfunctioning of the zona fasciculata, right, that is zona fasciculata will produce the corticosteroids. So if there is hyperfunctioning of the zona fasciculata, the individual will end up in what is called the Cushing syndrome. So in case of Cushing's, there is increased cortisol. Then if there is increased aldosterone synthesis, that is called hyperaldosteronism, and we see that in patients with the Conn syndrome, right? We see that in patients with the Conn syndrome. Then followed by that, if there is excessive production of the adrenal androgens, that will result in what is called the virilization in women. That will result in what is called virilization in women. So these are the disorders of the hyperfunctioning of the adrenal gland: Conn syndrome, Cushing syndrome, and as well as the virilization in women. Now, so you can see this image here. So we have the outer zona glomerulosa, then middle we have zona fasciculata, and innermost layer will be the zona reticularis. And within this adrenal cortex or beneath the adrenal cortex, you have the medulla, which will produce the catecholamines, that is epinephrine and as well as the norepinephrine. Then followed by that, if we take up the discussion of the Cushing's. So Cushing syndrome is what? It is the disorder where there is excessive production of the steroids. So if you take the common cause, most common cause of the Cushing syndrome, it is due to exogenous steroid supplementation, that is iatrogenic steroid supplementation. That will be the most common cause of the development of the Cushing syndrome. Then followed by that, how do you classify the etiology of the Cushing syndrome? See, Cushing's, we classify this in the following manner. The etiology, we classify that as ACTH dependent and ACTH independent. What do you mean by the word ACTH dependent? There is excessive production of the ACTH from the anterior pituitary, that is corticotroph type of pituitary adenoma, right? Corticotroph type of pituitary adenoma. Whereas ACTH independent, if you see here, the pathology will be in the adrenal gland, that is adrenal tumors. So now let me discuss what are the ACTH dependent and ACTH independent causes for Cushing's. So first, if you see the ACTH dependent type of Cushing's, ACTH dependent type of Cushing's include number one, the pituitary adenoma, that is corticotroph type of pituitary adenoma. Then ectopic ACTH production. Now what are the causes of the ectopic ACTH production? See, the causes of ectopic ACTH production include number one, small cell carcinoma of the lung, which is also called oat cell carcinoma of the lung. Then followed by that, medullary carcinoma of thyroid. Medullary carcinoma of thyroid is the malignancy or the tumor where there is excessive production of calcitonin, right, where there is excessive production of calcitonin. Then pheochromocytoma, it is a tumor of the adrenal medulla. And then pancreatic and bronchial carcinoids. So these are the causes for ectopic ACTH production. Next, followed by that, what is the most common cause of ACTH dependent type of Cushing's? ACTH dependent type of Cushing's, the most common cause will be pituitary adenoma. And what type of pituitary adenoma is that? That is corticotroph type of pituitary adenoma. Then you need to know what is the most common cause of ectopic ACTH production. Ectopic ACTH causing Cushing's, the most common cause will be small cell carcinoma of the lung, which is also called the Ott cell carcinoma of the lung. Then, what are the causes of ACTH independent type of Cushing's? See, in ACTH independent type of Cushing's, the pathology is directly within the adrenal gland, that is the adrenal tumor. Now, what are these adrenal tumors? That includes number one, the adrenal adenoma, then followed by that the adrenal hyperplasia. So these will be the causes for ACTH independent type of Cushing's. Now, what are the clinical features of the Cushing syndrome? The clinical features of the Cushing syndrome include number one, the deposition of the adipose tissue in various sites of our body. The adipose tissue excessively gets accumulated in the face, resulting in the swelling or round face. The adipose tissue gets accumulated in the nape of the neck, that will result in buffalo hump. The adipose tissue gets accumulated in the supraclavicular area, which will cause the supraclavicular filling. The adipose tissue will get accumulated in the abdominal area, resulting in the central obesity. So these will be the one of the very important clinical features of the Cushing's. In fact, the earliest feature of the Cushing syndrome is the weight gain. Right, the earliest feature of the Cushing syndrome is weight gain. Then the other features include the moon facies, interscapular buffalo hump, then mesenteric bed of fat, that will result in abdominal obesity, and that is nothing but your truncal obesity. So these are the earliest changes that will appear in patients with the Cushing syndrome. Then what are the other features apart from the weight gain and redistribution of the fat? The other features include hypertension, because in Cushing's there is excessive steroids. These increased steroids will increase the sensitivity of catecholamines on the blood vessels, and thereby the individual will develop hypertension. And they will have proximal muscle weakness. Now, why is that they will have proximal muscle weakness? That is because the steroids, when they are produced in excess quantity, they will cause proteolysis. They will cause the breakdown of the proteins, and because of which there will be proximal muscle weakness. The proteins in the body, they are mainly localized within the muscle. So there will be muscle breakdown resulting in muscle weakness. Then there will be fatigability related to mobilization of the peripheral supportive tissue. There will be osteoporosis. Why? Because these corticosteroids will stimulate the osteoclast. Right? So once they stimulate the osteoclast, they will cause the bone resorption, resulting in osteoporosis. Then followed by that, the cutaneous striae and easy bruisability. So why is that they have cutaneous striae and as well as the easy bruisability? That is because when there is excessive steroid production, there is excessive accumulation of the fat or free fatty acids beneath the skin. Right? Excessive free fatty acids being accumulated beneath the skin, and these free fatty acids, when they are excessively deposited beneath the skin, that will make the individual to have stretch of the skin, resulting in the cutaneous striae. And this particular cutaneous striae, they are purple in color, that we call it as purple striae, right? And there will be also degeneration of the skin, due to which they will have the easy bruisability, right? So these are the other features of Cushing's. Now, what are the features of Cushing's in women? Let me tell you that there is adrenal cortical hyperactivity in Cushing's. Because of adrenal cortical hyperactivity of Cushing's, there will be also increase in adrenal androgens. Because of increase in adrenal androgens in women, these adrenal androgens, they will cause the features of the virilization. They will have acne, hirsutism, oligomenorrhea, and as well as the amenorrhea. So these are the features of Cushing's in women. Next, followed by that, you need to know what are the CNS manifestations in Cushing's. What are the CNS manifestations? CNS manifestations that include the irritability or the emotional lability. So this irritability or emotional lability is due to excessive firing of the cerebral neurons in Cushing's, and there will be also psychosis which will develop, right? So these are the CNS manifestations in Cushing's. Now followed by that, what happens to carbohydrate metabolism in Cushing's? Let me tell you, these individuals, they will have the glucose intolerance. So these steroids, they will increase the hepatic gluconeogenesis, and due to which there will be glucose intolerance in these patients with the Cushing's. Then, what is the electrolyte abnormality that will happen in Cushing's? Electrolyte abnormality, they will have sodium and water retention, and there will be potassium excretion resulting in the hypokalemia. Why is that? Because these increased steroids will go and act on the mineralocorticoid receptors, right? That increased steroids will go and act on the mineralocorticoid receptors, and that will cause sodium and water retention and potassium excretion resulting in the hypokalemia. So this will be the electrolyte abnormality in Cushing's. Then why there is hypokalemia? That is what is the mechanism I have taught you. That is because of the mineralocorticoid effect of the steroids. They will have the hypokalemia. So hypokalemia occurs because of the mineralocorticoid effect of the steroids. Then followed by that, why there is renal calculi in Cushing's, right? Why there is renal calculi in Cushing's? So why there is renal calculi in Cushing's is because there is excessive release of steroids in Cushing's, and these steroids, they have osteoclastic activity, and once there is osteoclastic activity, that will result in the bone resorption. Thereby there will be hypercalcemia. So whenever there is hypercalcemia, that will result in the accumulation of the renal calculi. The calcium, it gets deposited in the form of the renal stones. So there will be renal calculi from increased calcium levels, right? Renal calculi from increased calcium levels. Okay, right. Next, followed by that, why there is impaired wound healing in patients with the Cushing's? Because in patients with Cushing's, they have the hyperglycemia, and the immunity of the individual is less in patients with the Cushing's because of excessive steroid production. Due to these two reasons, there is delayed wound healing or impaired wound healing in patients with the Cushing's. Then why there is polyuria in patients with the Cushing's? See, there is hyperglycemia, and this glucose starts getting excreted out in the urine, and that will result in polyuria. So polyuria, it is from hyperglycemia. Please remember, it's a very important point. Next, why there is increased susceptibility of infections in Cushing's, right? Why there is increased susceptibility of infections in Cushing's? Why is that? That is because the neutrophil levels will be reduced in patients with the Cushing's. So basically, the levels will reduce in the sense the neutrophil activity will be reduced, and that is the reason why they are prone for infections. Okay, so these are some of the important features of the Cushing's and etiology of the Cushing's. And in the next session, I will be taking up how do you manage, that is management of the Cushing syndrome. Thank you very much.